Alright guys, let's get busy talking about uterine cancer. When it comes to uterine cancer, we can have our cancers either in the endometrial lining, which I'm going to be outlining here in pink, and we can also have our cancers that are going to be localized to the muscularis layer, which is out here in the uterine myometrium. So you can see that these would be cancers of the muscle, whereas the other cancers would be cancers of the endometrial lining. So let's go ahead and get into it. Let's start by talking about cancers of our endometrial lining, specifically endometrial carcinoma. And essentially what's happening here in endometrial carcinoma is it's going to largely affect postmenopausal women who've had a long exposure of estrogen. And so this prolonged estrogen exposure is going to lead to endometrial transformation. We know that endometrial tissues are really sensitive to estrogen. It causes them to grow and be active. And so after prolonged years of estrogen exposure, this can actually lead to transformation into cancer. And so if we think about it, it's going to be our postmenopausal women with a history of estrogen exposure. And there's a lot of things that can cause estrogen exposure. We'll talk about a few. So patients who are obese are going to have increased peripheral estrogen creation. Patients with PCOS are classically in a prolonged estrogenic state. And then late menopause means you have more years with a menstrual cycle. And we know that menstrual cycles have periods of high estrogen, and then also nulliparity. If you've never been pregnant, you've never had that 9 months of your life where your body is dominated by progesterone, and therefore your body was being dominated by estrogen at that time point. So all of these estrogenergic states are going to lead you to have a higher risk for endometrial cancer. And so this is classically going to present as abnormal uterine bleeding. And when we think about postmenopausal women, all bleeding from the vaginal orifice is going to be abnormal because these women have stopped menstruating. And so if we see bleeding in a postmenopausal woman, we need to have uterine cancer on our differential. So how are we going to identify these uterine cancers? It's going to be all about biopsy. So we're going to be talking about two different types. So in green, I'm going to be talking about the endometrioid type, and then in blue, we're going to be talking about the serous type. So let's go ahead and take a look at some of this histology here, starting with endometrioid type. This is going to be the type that's really going to be common in people who had increased estrogen exposure. So this unopposed estrogen exposure plus some sort of molecular cancer derangement, for example, P10 or mismatch repair protein loss, are going to be big ones for endometrial cancer. And together, these two factors are going to lead to transformation. And we expect to see on histology abnormally arranged endometrial cells. So let's go ahead and zoom in and take a look at this. Here we would see an example of what would be normal looking endometrial tissue, and then you see we have like these areas here where we have a lot of purple mitotic activity and this loss of organization. So what I'm pointing to with my arrow here would be the area where we would expect to see the endometrial cancer. And so I just wanted to point that out, but let's also compare it to our serous type. So this is going to be due to endometrial atrophy, and we know that the endometrium is going to atrophy in our postmenopausal patients. And eventually this is going to lead to transformation, and this type tends to be very aggressive. And so on the histology for these, you're going to see papillae and tufts plus or minus psammoma bodies. So let's go ahead and take a look here. In terms of our psammoma bodies, these are going to be these beautiful concentric circular rings of calcium deposits. They're really easy to spot, and these are going to be easy points. And so this would be a great way to differentiate two different types of endometrial cancer if you were given a biopsy on test day. Let's move on now to talking about our endometrial or uterine polyps, and essentially these are going to be really similar to endometrial cancer. However, they are much smaller and they're going to be benign. So just like in our endometrial cancer, this is all about prolonged estrogen exposure, and this estrogen exposure is basically going to lead to little tufts or clumps of endometrial tissue that has grown and just kind of solidified in one spot of the uterus, and it's going to be described as a discrete collection of benign endometrial tissue. And this is going to present the same. It's going to be a postmenopausal patient with abnormal uterine bleeding, and so if you get in there and do the biopsy, you're going to see a small localized discrete patch of tissue, and the tissue is going to be just like normal endometrial tissue that has all clumped up. There's going to be no transformation, no signs of malignancy in terms of like high mitotic activity or disorganized endometrial tissue. And so we're just really going to manage this symptomatically. So if these need to be removed surgically, we can do that, or we can just treat these patients with supportive care. But just to go over our etiology again, this is going to be the postmenopausal menopausal women with history of estrogen exposure presenting with abnormal uterine bleeding, and we're going to have normal histology findings in this case, similar to the histology that we talked about here in the normal appearing endometrial tissue. Let's move on now to talking about our leiomyoma, also called fibroids. Fibroids are a really common name for this. Leiomyoma is a bit difficult to say, so you will usually hear this as fibroids on exam, and these are also going to be estrogen sensitive tissues. However, we are now talking about growth of the myometrium. So if you remember in the beginning, I talked about this pink area here in our uterus as being the endometrial lining, and then this orange layer being the muscularis layer. And so now we're talking about cancers in the muscular part of the uterus as opposed to the endometrial part of the uterus. And essentially this is going to be a benign smooth muscle tumor, and so there is no chance of malignancy here with fibroids. However, it doesn't mean that they're without pathology or without bothersome problems. And so a classic patient vignette here for fibroids would be a 31-year-old black patient who is showing up with abnormal uterine bleeding. Perhaps they're bleeding a lot between periods, and this could be heavy bleeding, it could be painful bleeding. They might have things like constipation or recurrent pregnancy loss or just inability to get pregnant in the first place. These are going to be a common presentation of a patient with fibroids. And then you go to do a physical exam, and the classic physical exam finding is going to be an enlarged asymmetric, non-tender uterus, and we will explain why this physical exam finding is the way it is. Let's kind of take a look at one of these images here, and you'll see that in this image I have here of this gross pathology, these are discrete muscular tumors, right? And you can see in this larger picture we have these discrete blobs of muscular tumor all throughout the uterus. And if you were to feel this with your hands, it would feel like this irregularly shaped uterus that's not particularly painful on physical exam because it's just benign muscle tissue, and it's going to be asymmetric. That's the key here, as opposed to adenomyosis, which we usually think of as a globular, symmetric, enlarged uterus. So that's going to be a high yield finding here. And then in terms of our epidemiology, we talked about the fact that this is going to be females 20 to 40 years old, and usually in question stems they like to mention that there's an increased incidence in our black patients. And then in terms of our complaints, I talked about a few in our vignette, but let's go over them all. We can have abnormal uterine bleeding. Sometimes this will sneak into a question as a microcytic anemia, for example, iron deficiency anemia, due to really heavy periods from these fibroids. And then we can have pelvic pain, miscarriage, urinary frequency, and constipation. And this urinary frequency and constipation is because we know our ureters and our rectum are really close to our uterine cavity. And so if we get these big muscular masses pushing on other architecture around, they're going to lead to urinary or bowel symptoms, and that's why these patients can oftentimes present with that. In terms of our histology, let's take a look here. We're going to get this description here of these benign smooth muscle bundles, and you can see that it's fairly well organized. There doesn't appear to be any mitotic activity here, and it's going to be described as multiple discrete tumors displaying this whorled, well-demarcated, smooth muscle bundles. And you can see here that if we were to look at this on gross pathology, you see that they have these well-defined, discrete muscular tumors all throughout the uterus, and this is going to be how it presents on test day. And classically, what I would imagine a test writer would want to do is imagine they put 3 dots on a diagram of a uterus. Well, let's make it actually 4 dots and say, okay, here we go. And then they said, all right, this is A, B, C, and D, and they're asking you, all right, where are we going to expect to find a fibroid if we were to go in and take a biopsy? And they're testing your ability to identify that in here around C is going to be endometrial cancer territory. Out here in A is going to be ovarian cancer territory. Up here in D is going to be cervical or vaginal territory, right? So they want you to be able to know that this irregularly enlarged uterus is due to all this bumpiness out here in the area dominated by B. And this is going to be how they're going to ask about fibroids on exam day. They really like you to know that fibroids cause this irregular shape because they're just so big and obtrusive, and that's like the key to their pathophysiology. Now let's move on to talking about leiomyosarcoma, which is like a relative of fibroids, but they actually don't come from fibroids. They're actually their own thing, and so they're going to be a malignant neoplasm of the myometrium. So we are still talking about the muscular portion of the uterus, but these are not arising from from fibroids, and that's really important. So I'm going to highlight it in a separate color. These do not transform from leiomyoma, and I'm going to highlight it again up in the fibroid section. These do not transform into leiomyosarcoma, and that's important because these both have really similar sounding names. In fibroids, it's called leiomyoma, and then in the leiomyosarcoma, it's just a slight change in the language of these two disease processes, but in their level of prognosis, leiomyosarcoma is so aggressive and so lethal, and so it's important to be able to differentiate these on test day. So when it comes to test day and leiomyosarcoma, they're going to talk about the fact that this is going to be way more common in our postmenopausal females, whereas our fibroids were classically going to be premenopausal females. And then if we were to get histology, we would see a single tumor displaying areas of necrosis, whereas if we talked about the histology of our fibroids, which is what you're most likely to see on exam day, it would be this well-organized whorled pattern without any mitotic activity or signs of transformation or penetration of basement membrane, nothing concerning like that. So that's going to be how you're going to differentiate these two on exam day. In terms of our high yield review, it's important to note that all of these tumors are going to be related to increased estrogen exposure, but it's important to know that endometrial carcinoma and uterine polyps are going to be in the endometrial lining, whereas our leiomyoma are going to be out in the muscular region. When it comes to presentation, we expect uterine cancer to be in our postmenopausal females, whereas fibroids are going to be in our premenopausal females, especially those presenting with abnormal uterine bleeding and things like constipation and urinary complaints and miscarriages. Additionally, the histology is going to be important. We expect muscular looking histology in fibroids, whereas we're going to expect endometrial type histology in our endometrial cancers. And when it comes to our description of the uterus for fibroids, it's going to be super high yield to know that this is going to be an asymmetrically enlarged uterus. You can appreciate this here with this gross specimen that is just super bumpy and irregular. And then it's important to know that leiomyosarcomas do not come from fibroids. They are extremely aggressive, and they're going to be described as central areas of necrosis on histology, and it's important to know that the prognosis for these is very poor. I hope you guys enjoyed this video. I can't wait to see you guys in the next one. Bye!